All right, welcome everyone. In this clinical refresher, we are going to cut right through all the noise. We're going to break down the latest Canadian dyslipidemia guidelines into the most practical, ready-to-use takeaways for your pharmacy practice.
Okay, let's just jump right in with the question we all hear probably every single day at the counter, right? My muscles are aching. Is it my statin? We're going to walk through exactly how to handle this using the 2021 Canadian Cardiovascular Society guidelines, so you can feel totally confident in that conversation.
So first things first, before we can even talk about treatment, we have to figure out who we're treating. The guidelines give us a really clear roadmap for this, who automatically gets a statin and how we assess the risk for basically everyone else.
And here's the easy part, our starting point. The guidelines really simplified things for us with 4 key high-risk groups. You see a patient with established atherosclerotic cardiovascular disease, chronic kidney disease, or diabetes, they're on the list. Or if their LDL-C is sky-high, we're talking 5 millimoles or more, they're on the list too. A statin is recommended, period. It just takes all the guesswork out of it for these really vulnerable patients.
Okay, but what about everyone else? For them, we pull out our trusty risk assessment tool, the Modified Framingham Risk Score. Now, it's pretty much the standard FRS you know, but with one really crucial tweak. You have to double the score if the patient has a family history of premature cardiovascular disease. And that little change helps us sort everyone into low, intermediate, or high risk, which, you guessed it, tells us exactly how to approach their treatment.
All right, let's get to the main event, statins. I mean, they're called the cornerstone of therapy for a reason, right? The evidence behind them is just so powerful, it's why we rely on them day in and day out.
Okay, if there's one number you take away from this, make it this one, 21%. Think about that. For every single 1 millimolar drop we get in a patient's LDL-C, we see a 21% relative risk reduction in major vascular events. That is huge. It's such a powerful and tangible number you can share with your patients to really drive home why this medication is so important.
So how do we actually get that drop? Well, we group statins by how potent they are. You've got your low-intensity statins, like a low dose of pravastatin, which will give you a pretty modest reduction, think less than 30%. But then you step it up to a moderate-intensity statin, something like atorvastatin 20 milligrams, and now you're aiming for a much more significant drop, somewhere in that 30 to 50% range. But for our highest risk folks, especially if they've already had an event, secondary prevention, we've got to be a lot more aggressive. And that's where the high-intensity statins come into play. We're talking about making moves like going from rosuvastatin 10 milligram up to 20 milligram. That's what helps us blast past that 50% LDL reduction target.
And of course, all this talk about high-intensity therapy leads us right to what is, let's be honest, a massive part of our job, managing those patient-reported side effects. This is really where we as pharmacists get to shine, navigating those tricky patient concerns.
Okay, so your patient comes in and says, my muscles ache. The guidelines give us a great systematic way to handle this. First step, really assess those symptoms. You want to ask, is the pain symmetrical? Is it in those big muscle groups like the thighs? Step 2, be a detective. Rule out other stuff. Did they just start a new workout routine? And then step 3, if it still seems like it could be the statin, you can consider a de-challenge and then a re-challenge, maybe with a different statin, before you jump to labeling it a true intolerance.
And we also have to keep our eyes peeled for factors that can put someone at a higher risk for these muscle issues. We're talking about things like being over 80, female sex, a low BMI, and a big one, untreated hypothyroidism. It's also super important to remember that individuals of Asian descent can have higher drug levels of some statins, which bumps up their risk. And of course, this is our bread and butter, watching out for those drug interactions, especially with major CYP3A4 inhibitors, like macrolides or azyl antifungals.
Here's another one we hear about a lot, the risk of new-onset diabetes. And yeah, there is a small, documented risk, especially with the high-dose statins. But here's the bottom line, the crucial point we need to communicate. For any patient who's at high cardiovascular risk, the benefit of that statin preventing a heart attack or a stroke absolutely 100% outweighs that small risk of diabetes. It's not even close.
So what do we do when a patient is on the highest dose of a statin they can handle, but they're still not at their target LDL? Or what if they just flat out can't tolerate statins? Well, the guidelines give us a really clear pathway for what comes next, our add-on and alternative therapies. Okay, let's do a quick side-by-side. You can see the huge range you get with statins, right? Then you have ezetimibe, which gives you a reliable, extra little drop. And then there are the heavy hitters, the PCSK9 inhibitors, with that massive reduction.
And notice icosapent ethyl on there. It's a bit different. Its benefit doesn't actually come from lowering LDL, which is a key point we're going to touch on in a second.
So, in your day-to-day practice, you can really think of ezetimibe as your go-to second-line drug. Why? Because it's super well tolerated, and we have the Improve It trial that showed it provides a real benefit, yeah, it's modest, but it's there, in reducing coronary events when you add it on top of a statin for post-ACS patients. Plus, it's a fantastic choice for our patients with chronic kidney disease.
Now, for your really high-risk patients, I'm talking about people with familial hypercholesterolemia who are still nowhere near their goal even on a max statin dose plus ezetimibe. For them, PCSK9 inhibitors are an absolute game changer. I mean, an additional 60% drop in LDL? That's just profound. It can literally make a life-saving difference.
And this is where icosapent ethyl has carved out its niche. This is the drug you need to be thinking about for your patients who are on a statin. Their LDL looks great, but they still have this residual risk because their triglycerides are high. The Reduce It trial was huge for this. It showed a whopping 25% reduction in major adverse cardiovascular events, specifically for this group.
Okay, we've covered a lot of the clinical stuff, so let's boil it all down. Let's do a rapid-fire round of the most critical counseling points you can literally start using at the counter tomorrow.
This is always where the conversation should start. For your high-risk patients, you have to be clear. The medication is not optional, but, and this is a big but, it works so much better when it's part of a team with diet and lifestyle changes. Make sure they understand one doesn't replace the other. They're a package deal.
And please, when you're counseling on diet, be specific. Don't just say eat healthier. That doesn't help anyone. Give them these evidence-based, actionable goals. Tell them about getting at least 2 grams of plant sterols a day or 10 grams of viscous soluble fiber. These are real targets they can aim for that we know actually work to lower LDL.
Okay, this one is so important to get right. If you have a patient of childbearing age, you need to be able to tell them with confidence, statins have to be stopped before they try to conceive. And if lipid-lowering therapy is absolutely 100% necessary during the pregnancy, then the bile acid sequestrants, the resins, like cholestyramine, are the go-to choice. And speaking of those resins, here's the most crucial counseling point, and it is absolutely non-negotiable. Timing. You have to hammer this home. They must separate it from their other meds. The rule is simple. Take other drugs either 1 hour before the resin or wait 4 to 6 hours after. If they don't, they risk messing with the absorption of everything else they're taking.
Now here is a fantastic, practical pro tip for that patient who is really struggling with side effects. Let's say they're very high risk, so they need that big LDL drop, but they just can't handle a daily high-intensity statin. The guidelines actually support using atorvastatin or rosuvastatin on alternate days, and that is a much better strategy than just giving up and switching them to a weaker, less potent statin.
So this really leaves us with one final thought, doesn't it? The evidence for these drugs is it's overwhelming. It's so clear. So our focus as pharmacists really has to shift. It's about communication. It's about partnership. The real question is, how can we get better at addressing patient fears, managing those side effects, and ultimately improving adherence so that every single one of our patients can get these incredible life-saving benefits?